Anatomy and physiology. The central structures of the brain include the cerebrum, the brainstem, and the cerebellum. Cerebrum, largest and most highly developed part of the brain. It has many complex functions, including initiation of movements, recognition of sensory input, higher-order thinking, regulation of emotional behavior, and regulation of endocrine and autonomic functions. The cerebrum is divided into two halves, called hemispheres, connected by the corpus callosum. Each hemisphere controls the opposite side of the body. For most people, the left hemisphere is dominant, right-handed. This hemisphere controls the more analytic mental processes such as language acquisition and use, mathematics, and reasoning powers. The right hemisphere encompasses emotional and artistic tendencies. The outer layer of the cerebrum is called the cortex. Each hemisphere of the brain is divided into the parietal, frontal, temporal, and occipital lobes. Each lobe has a different area of function. Brainstem includes the midbrain, pons, medulla, and part of the reticular activating system. The brainstem controls vital basic functions, including respiration, heart rate, and consciousness. Cerebellum uses information received from the cerebrum, muscles, joints, and inner ear to coordinate movement, balance, and posture. Unlike the cerebrum, the right side of the cerebellum controls the right side of the body and the left side of the cerebellum controls the left side of the body. Circulation. The brain is rich with arterial circulation to satisfy its high need for oxygen. Although the brain comprises only 2% of the body's weight, it consumes 20% of the oxygen supply and cardiac circulation each minute. The two major arterial systems that supply the brain are, 1. The carotid, and 2. The vertebral arteries. The carotid system begins as one common artery that later divides into the external and internal carotid arteries. The external carotid arteries divide to supply blood to the face. The internal arteries further divide into the missile cerebral artery and the anterior cerebral artery to supply blood to the brain. The vertebral arteries originate from the subclavian artery and travel up the anterior neck to merge and form the basilar artery at the brainstem. A second division forms the posterior cerebral artery. The internal carotid arteries and vertebral basilar arteries unite to form the circle of Willis. Some people have anatomic differences in blood vessels that can increase the likelihood that they will sustain a CVA. A cerebrovascular accident, CVA, is an interruption of blood flow to part of the brain. Without normal blood flow, the affected area is deprived of oxygen and cell death begins to occur in as little as 4 minutes. The effects of oxygen deprivation vary depending on the area of the brain involved and the length of time the brain is deprived of oxygen. If blood flow is restored to the deprived area in time, recovery of the brain tissue may occur. Commonly referred to as a stroke or brain attack. Fifth leading cause of death and the leading cause of adult disability in the United States. Nearly 795,000 Americans experience a new or recurrent stroke each year, resulting in the deaths of approximately 130,000 people annually. The economic effect of stroke is estimated to be more than $60 billion each year, with monies spent on treatment, medications, and missed work. Approximately 7 million Americans are stroke survivors. Stroke is considered one of the most preventable of catastrophic events in the United States. Signs of a stroke: sudden numbness or weakness of the face, arm, or leg, especially on one side of the body. Sudden confusion, trouble speaking or understanding. Sudden trouble seeing in one or both eyes. Sudden trouble walking, dizziness, loss of balance or coordination. Sudden, severe headache with no known cause. Risk factors. Classified as modifiable and non-modifiable. Non-modifiable factors are risk factors that cannot be changed: age, race, gender, heredity, having had a previous TIA or CVA, fibromuscular disease, and patent foramen ovale. CVAs are more common in men, African Americans, people 51 to 74 years of age, and those with a family history of CVA. Stroke has been considered mostly a disease of older individuals, but at least 5% of strokes occur in individuals younger than 45 years of age. Causes of strokes among the young include drug abuse, use of birth control pills in combination with smoking, congenital heart conditions, mitral valve prolapse, atrial fibrillation, infectious endocarditis, sickle cell anemia, rheumatic fever, and leukemia. Health promotion. Spread the word about risk factors for and warning signs of stroke. Assist patients in addressing and lowering their risks for stroke. Participate in community education programs for cardiovascular health. Get involved in Operation Stroke in your community. Participate in stroke and blood pressure screenings. Promote evidence-based care and best practices for a healthy lifestyle. Engage in and promote physical activity. Participate in anti-smoking campaigns and assist patients to locate such programs. Recognize depression after stroke and help patients to obtain adequate treatment. Discuss transient ischemic attack treatment and patient teaching and stroke, pathophysiology, ischemic stroke. Transient ischemic attack. A transient ischemic attack, TIA, is a transient episode of neurologic dysfunction caused by focal brain, spinal cord, or retinal ischemia, without acute infarction, Easton et al., 2009. Blood vessels may be occluded by spasms, fragments of plaque, or blood clots. It is believed that at least 85% of blood flow to an area must be blocked before signs and symptoms of a TIA appear. These episodes of temporary neurologic changes were previously thought to be benign. It is now known that TIAs are important warning signs for the individual who could potentially experience a full stroke in the future. Previously, TIA was defined as lasting less than 24 hours, but it is now defined as a temporary onset of stroke symptoms without permanent damage. It is recommended that a patient experiencing a TIA receive a full medical evaluation within 24 hours. This may be completed in an inpatient or outpatient setting. A TIA is a warning sign for stroke. 10 to 15% of patients have a stroke within 3 months, with half occurring within 48 hours, Easton et al., 2009. Approximately 30% of individuals who experience a TIA have a stroke within 5 years. One tool used to assess the risk of stroke after TIA is the ABCD2 score. Points are assigned based on age, blood pressure on first evaluation, clinical symptoms, and duration of symptoms and diagnosis of diabetes. The score can range from 0 to 7, the greater the score is, the more increased the risk of stroke is within 2 days. Signs and symptoms. With TIA, neurologic signs and symptoms resolve with no permanent effects. Some common signs and symptoms of TIA are dizziness, momentary confusion, loss of speech, loss of balance, tinnitus, visual disturbances, ptosis, dysarthria, dysphagia, drooping mouth, weakness, and tingling or numbness on one side of the body. The nature and severity of the symptoms depend on the area of the brain involved and the extent of tissue deprived of adequate oxygen. Medical diagnosis. TIA is generally suspected based on the health history and physical examination findings. Confirmation requires brain imaging studies, preferably with magnetic resonance imaging, MRI. In addition, non-invasive imaging of blood vessels, laboratory studies, and cardiac evaluation may be ordered to detect risk factors for TIA and stroke. Non-invasive vascular studies can show narrowing of cervical and cerebral blood vessels. Doppler studies may also be done to assess cerebral blood flow. Ultrasonic duplex scanning is useful in detecting carotid artery disease. Computed tomography, CT, and electroencephalogram, EEG, may be used to rule out intracranial lesions such as tumors, aneurysms, and abscesses. Treatment. Treatment of TIA depends on the cause. The common causes of TIA are thought to be carotid artery disease, large or small artery disease from atherosclerosis, and atrial fibrillation. The treatment of atherosclerotic disease depends on the location of the narrowed vessel and the degree of narrowing. Based on research evidence, the American Stroke Association recommends initial treatment with acetyl-salicylic acid, aspirin, alone or combination of acetyl-salicylic acid and extended-release dipyridamole, Agrenox, or a combination of acetyl-salicylic and with clopidogrel bisulfate, Plavix, to decrease platelet clumping. In atrial fibrillation, microscopic emboli are believed to form, which later are released from the heart and travel to the arteries of the brain to cause TIA or stroke. There are new anticoagulant medications available for the prevention of cardioembolic TIA. The only options used to be warfarin, Coumadin, and heparin for patients exhibiting a cardioembolic TIA. The dosage for warfarin therapy is based on the prothrombin time, PT, and the International Normalized Ratio, INR. For therapeutic anticoagulation, the PT is usually kept in a therapeutic range of 1.5 to 2.0 times normal and the INR at 2.0 to 3.0. The effect of unfractionated heparin therapy is monitored with the activated partial thromboplastin time, APTT. Rivaroxaban, Xarelto, and dabigatran, Pradaxa, are also indicated for stroke prevention in nonvalvular atrial fibrillation. The decision for medication should be individualized to the patient based on the medical evaluation of the TIA, possible risk factors, how the patient tolerates the medication, and other health issues. Kernan et al., 2014, if low molecular weight heparin, enoxaparin and others, is used, laboratory values for heparin anti-XA may be monitored. Statin drugs are recommended for patients with elevated lipids or coronary artery disease, or when evidence exists that the TIA is related to atherosclerosis. Treatment of hypertension is recommended as well. Because of the operative risks and controversy about the value of surgical intervention in terms of stroke prevention, surgery is often reserved for the most serious stenosis. The most common surgical procedures are carotid endarterectomy and transluminal angioplasty. Carotid endarterectomy is the surgical removal of plaques in the artery to permit improved blood flow. Patients who are at high risk for surgical intervention because of other health problems may benefit from angioplasty. A stent may be placed in the artery to keep it open. Transluminal angioplasty improves blood flow by dilating the narrowed artery with a balloon that is inserted into the artery. A patent foramen ovale is sometimes identified in the patient with TIA. Closure of this defect in the heart can be accomplished through an open surgical approach or a transcatheter closure. Stroke, abrupt impairment of brain function resulting in a set of neurologic signs and symptoms caused by impaired blood flow to the brain and that last more than 24 hours. When symptoms progress over hours or days, the condition is described as stroke in evolution. When the neurologic deficits do not change for 2 to 3 days, the stroke is said to be completed. Unlike TIA, a completed stroke causes lingering motor, sensory, or cognitive damage with varying disabilities. As noted earlier, stroke is the 5th leading cause of death and the leading cause of adult disability in the United States. Approximately 795,000 Americans experience strokes each year, resulting in the deaths of approximately 130,000 people annually. When the occurrence of TIAs is added to these numbers, the total may reach 2 million CVAs each year in the United States alone. Acute care and rehabilitation of stroke patients is a long and expensive process. Advances in care have improved the outlook for many individuals who experience a stroke. More than half of stroke victims acquire independence in activities of daily living, ADL, within 1 year after the stroke. 30% of stroke survivors return to work or productive lives within 1 year. These are important figures to remember when caring for the stroke patient. Patho, the 2 main classifications of stroke are, 1, hemorrhagic and, 2, ischemic. Hemorrhagic stroke accounts for only about 13% of all strokes. In hemorrhagic stroke, a blood vessel in the brain ruptures and bleeding into the brain occurs. As a result, intracranial pressure, ICP, may increase, disrupting normal cerebral function. Hemorrhagic strokes are further classified by location. An intracerebral, within the cerebrum, hemorrhage, 10% of all strokes, is associated with trauma, uncontrolled hypertension, and aneurysms. When a hemorrhage occurs within the spaces of the brain, the terms subdural, subarachnoid, or ventricular are used to describe the location. Hemorrhagic strokes are often sudden in onset and require emergent, life-sustaining treatment. A subarachnoid hemorrhage, 3% of all strokes, occurs between the arachnoid and pia mater layers of the brain covering. The pia mater is the thin membrane covering the brain. The arachnoid covers the pia mater. Subarachnoid hemorrhage may be caused by congenital malformations of blood vessels in the brain or by rupture of an aneurysm. Ischemic stroke, caused by the obstruction of a blood vessel by an atherosclerotic plaque, a blood clot, a combination of the two, or other debris released into the vessel that impedes blood flow to an area of the brain. Brain cells deprived of blood flow become ischemic and die. Ischemic strokes account for 87% of all strokes, including embolic and thrombotic strokes. In an embolic stroke, the clot, or plaque fragment is traveling through a blood vessel from an area outside of the brain until it lodges in a cerebral artery. Mitral valve stenosis, atrial fibrillation, and myocardial infarction are cardiovascular conditions that may lead to the development of clots that become emboli. A thrombotic stroke develops when an obstruction forms in a blood vessel of the brain. The atherosclerotic process, which often affects large cerebral arteries, produces most of the thrombotic strokes. Patients may experience stroke in evolution, in which symptoms worsen during approximately 48 hours. As the obstruction progresses, neurologic impairment increases. Patients who have thrombotic strokes may have a history of TIAs. A lacunar stroke results from occlusion of the small penetrating arteries deep within the brain. Lacunar strokes account for about 25% of all ischemic strokes. A lacuna is defined as an empty space, the result of tissue death from an occlusive process in the small arteries of the brain. The clinical features associated with lacunar strokes are usually less severe and produce less pronounced neurologic changes. Risk factors for lacunar strokes include advanced age, chronic hypertension, smoking, and diabetes mellitus. Discuss signs and symptoms of stroke, include comparison of right and left brain damage. Aphasia. The speech center is located in the left hemisphere in more than 90% of all people. In left-handed persons, the speech center is sometimes located in the right hemisphere. If the speech center is damaged, communication is affected. Aphasia is a defect in the use of language, speech, reading, writing, or word comprehension. Aphasia is classified as receptive or expressive. The patient with receptive aphasia has difficulty understanding spoken or written words. The patient with expressive aphasia has difficulty speaking and writing. Aphasia can also be classified as fluent or non-fluent. The patient who has fluent aphasia sounds normal but makes little sense, whereas the person with non-fluent aphasia has difficulty initiating speech. Although these types of aphasia are distinctly defined, some patients have components of both types. The term global aphasia is sometimes used when speech is impaired to the point that the person has almost no ability to communicate. Dysarthria. Dysarthria is the inability to speak clearly. It is caused by neurologic damage that prevents normal control of muscles used in speech. Dysarthric patients are difficult to understand, but they understand what is said and have no difficulty putting together their thoughts. Dysphagia. Patients with dysarthria are also likely to have dysphagia, swallowing difficulty, which may require extensive rehabilitation. This is a very serious problem because of the risk of aspiration and pneumonia and because it can interfere with adequate nutrition. Dysphagia can be especially discouraging for the patient when attempts to eat result in choking, frustration, and fear. A gastrostomy tube may be inserted for long-term feeding purposes. Speech-language pathologists, SLPs, are trained to diagnose and treat patients with dysphagia. Dyspraxia. Dyspraxia is the partial inability to initiate coordinated voluntary motor acts. Any part of the body with motor function may be affected. For instance, the patient may not be able to walk or transfer to a chair without assistance even though the patient is not paralyzed. Patients with dyspraxia may be able to spontaneously perform a motor act yet be unable to initiate such an act willfully. This contradictory behavior can lead uninformed family, friends, or caretakers to assume that the person is being difficult. The difficulty initiating motor action seen in dyspraxia is quite different from the inability to perform motor acts because of hemiplegia. The person who has apraxia can move the affected parts but cannot perform specific purposeful actions such as walking or dressing. Hemiplegia. Hemiplegia is defined as paralysis of one side of the body. The affected side is opposite from the side of the brain in which the stroke occurred because nerve fibers in the brain cross over as they pass into the spinal cord. Hemiplegia is characterized first by flaccidity, decreased muscle tone, and then by spasticity, increased muscle tone. Recovery from hemiplegia is a gradual process and the extent of improvement varies widely. Sensory impairment. Impaired sensory function is common after a stroke. The patient may be unable to feel touch, pain, or temperature in affected body parts. Conversely, some hemiplegic individuals with S impairment perceive every sensation to the affected area as painful. Patients may feel as if their bodies are limp or flaccid. Altered sensations put the patient at risk for injury from pressure and excess heat or cold. Injuries may be ignored because the patient is not aware of them. Unilateral neglect. Patients may experience what is called unilateral neglect, in which they do not recognize one side of their body as belonging to them. Unilateral neglect is most common with right hemisphere damage and results in failure to attend to the left side of the body. The condition often resolves after about 3 months. Homonymous hemianopsia. Homonymous hemianopsia is a perceptual problem that involves loss of one side of the field of vision. Homonymous hemianopsia translates to a half-blinded field of vision that occurs on the same side in both eyes. At mealtime, the patient may leave half of the plate untouched, the half on the affected side. As another example, the patient may shave his face completely on one side and leave the whiskers untouched on his affected side. Intellectual and emotional effects. Many patients experience emotional changes after a stroke, sometimes to the point of personality change. Emotional lability is a frequent problem after a stroke. The patient may seem quite happy and then suddenly burst into tears for no apparent reason. Angry outbursts, childlike behavior, and inappropriate sexual behavior may occur. Emotional changes such as these are thought to be caused by neurochemical imbalances in the brain or by loss of the brain's ability to inhibit inappropriate behavior. It has also been found that cognitive processes may be slowed after a stroke, even without obvious deficits in thinking and responding. Elimination disturbances. In the acute phase of stroke and sometimes into the rehabilitation phase, the patient may experience a neurogenic bladder. A neurogenic bladder is further classified depending on the type of symptoms identified. A flaccid bladder, one without muscle tone, cannot empty completely. In some cases the coordination to be able to store urine in the bladder or wait once the urge to void is felt is lost, dyssynergia, which also leads to incontinence. Bowel incontinence may also be a physiologic consequence of stroke. However, confusion, disorientation, and immobility may contribute to incontinent episodes and to chronic constipation. With both bladder and bowel incontinence, it is important to determine if the cause is physiologic or related to other factors such as infection from a urinary catheter or the inability of the patient to communicate the need to go to the bathroom. Bladder and bowel, right brain damage, stroke on right side of the brain, left brain damage, paralyzed left side, hemiplegia paralyzed right side, hemiplegia, impaired speech/language, left-sided neglect, spatial perceptual deficits, tends to deny or minimize problems, rapid performance, short attention span, aphasias, impaired judgment, impaired time concepts to language, math, stroke on left side of the brain, impaired right/left discrimination, slow performance, cautious aware of deficits. Depression, anxiety, impulsive, Safety problems, impaired comprehension related. Discuss medical diagnosis, complications, and prognosis. Medical diagnosis: when a patient is admitted to a hospital with a tentative diagnosis of a stroke, the following procedures may be ordered: blood studies, electrocardiogram, ECG, CT, MRI, carotid ultrasound studies, Cerebral and carotid angiography, EEG, positron emission tomography, PET, and single photon emission CT. Blood studies and the ECG are done to identify the presence of risk factors for stroke, such as abnormal clotting, hyperlipidemia, and atrial fibrillation. If subarachnoid hemorrhage is suspected and the CT scan is negative for blood, a lumbar puncture may be performed to obtain cerebrospinal fluid, CSF, for examination. Grossly bloody CSF indicates hemorrhagic rather than ischemic stroke. This finding has important implications for treatment because anticoagulants are contraindicated after hemorrhagic stroke. A lumbar puncture is not done if increased ICP is suspected. Complications: patients who suffer an acute stroke are at risk for many complications related to impaired neuromuscular function. The patient with severe motor impairment is at risk for constipation, dehydration, contractures, urinary tract infections, thrombophlebitis, pressure injuries, and pneumonia. Sensory losses put the patient at risk for traumatic and thermal injuries. Swallowing difficulties places the patient at risk for pulmonary complications such as choking and aspiration pneumonia. Some patients experience disabling pain, called central post-stroke pain, CPSP, after stroke. The prognosis for patients experiencing TIA or stroke is becoming increasingly hopeful. The critical variables that affect recovery are the patient's condition before the stroke, the length of time between the occurrence of stroke and diagnosis, the treatment and support for the patient in the acute phase, usually the first 48 hours, the severity of the patient's symptoms, and access to rehabilitative therapy. Patients with acute stroke who have access to emergent care are treated with recombinant tissue plasminogen activator, RT-PA, within 90 minutes of symptom onset, have a better cure rate after 3 months than those treated later or not at all. To accomplish this requires a structured multidisciplinary approach to stroke care. Current national recommendations include medical systems to offer pre-hospital assessment and transportation, stroke centers, stroke units, and organized stroke teams. Because not all hospitals are equipped to handle the rapid evaluation and treatment of acute stroke, it is important that emergency medical services work closely with recognized stroke centers to transport patients to appropriate locations for this treatment. The long-term recovery of the stroke patient may well depend on the care received immediately after the stroke. Most recovery from stroke takes place in the first 3 to 6 months, but progress often continues long after that. The nurse's role in providing care to stroke patients is a vital one and has a significant effect on patient outcome. Discuss medical treatment in the acute phase. Include pharmacy capsule and discuss the medications in box table 28-2. Treatment. Treatment of TIA depends on the cause. The common causes of TIA are thought to be carotid artery disease, large or small artery disease from atherosclerosis, and atrial fibrillation. The treatment of atherosclerotic disease depends on the location of the narrowed vessel and the degree of narrowing. Based on research evidence, the American Stroke Association recommends initial treatment with acetyl-salicylic acid, aspirin, alone or combination of acetyl-salicylic acid and extended-release dipyridamole, Agrenox, or a combination of acetyl-salicylic and with clopidogrel bisulfate, Plavix, to decrease platelet clumping. In atrial fibrillation, microscopic emboli are believed to form, which later are released from the heart and travel to the arteries of the brain to cause TIA or stroke. There are new anticoagulant medications available for the prevention of cardioembolic TIA. The only options used to be warfarin, Coumadin, and heparin for patients exhibiting a cardioembolic TIA. The dosage for warfarin therapy is based on the prothrombin time, PT, and the International Normalized Ratio, INR. For therapeutic anticoagulation, the PT is usually kept in a therapeutic range of 1.5 to 2.0 times normal and the INR at 2.0 to 3.0. The effect of unfractionated heparin therapy is monitored with the activated partial thromboplastin time, APTT. Rivaroxaban, Xarelto, and dabigatran, Prognosis, are also indicated for stroke prevention in nonvalvular atrial fibrillation. The decision for medication should be individualized to the patient based on the medical evaluation of the TIA, possible risk factors, how the patient tolerates the medication, and other health issues. Kernan et al., 2014, if low molecular weight heparin, enoxaparin and others, is used, laboratory values for heparin anti-XA may be monitored. Statin drugs are recommended for patients with elevated lipids or coronary artery disease, or when evidence exists that the TIA is related to atherosclerosis. Treatment of hypertension is recommended as well. Dexamethasone, Decadron, reduces ICP by reducing inflammation in brain after stroke. Fluid retention, hypertension, hypokalemia, hyperglycemia, suppressed response to infection, fat deposits in cheeks and upper back, gastric ulcers, insomnia, easy bruising, mood swings. Dose usually tapered over 7 to 10 days to prevent acute withdrawal and adrenal insufficiency. Monitor INO, BP, blood glucose in people with diabetes. Protect from infection. Report even minor signs of infection. Protect from bumps and other minor injuries. Mannitol, osmitrol, glycerin, osmoglin. Induces diuresis, which reduces ICP. Mannitol is first-choice drug. Circulatory overload, heart failure, hypertension, renal failure. 15%, 25% mannitol solutions should be filtered. Monitor infusion site, stop flow and restart if infiltrated to avoid tissue damage. Monitor for signs of fluid volume excess, hypertension, bounding pulse, edema, urine output less than fluid intake. Anticoagulants. Unfractionated heparin sodium, liquemin sodium. Prevents formation of new blood clots, does not dissolve existing clots. Bleeding or hemorrhage resulting from excessive anticoagulation, hyperkalemia, alopecia allergy period. Effect is monitored by partial thromboplastin time, PTT, or activated partial thromboplastin time, APTT. Therapeutic goal is 1.5 to 2.0 times the control of 30 to 40 s. If patient's APTT is greater, withhold drug and contact physician. Assess for bruises, bleeding from GI and urinary tracts, mouth, or nose. Contraindicated with active bleeding. Low molecular weight heparin, enoxaparin, dalteparin, and others. Prevents formation of new blood clots, does not dissolve existing clots. Bleeding or hemorrhage, allergic reactions, injection site reactions, increases in liver enzyme tests. Lab values not routinely followed. If monitored, the anti-XA assay will be used. Protamine as an antidote will be only partially effective. Assess for bruises, bleeding from GI and urinary tracts, mouth, or nose. Contraindicated with active bleeding. Warfarin sodium, Coumadin, penwarfarin. Prevents formation of new blood clots, does not dissolve existing clots. Bleeding or hemorrhage resulting from excessive anticoagulation. Heparin antidote is protamine sulfate. Caution with venipuncture, apply pressure to site. Effect is monitored by prothrombin time, PT, and international normalized ratio, INR. Therapeutic goal is a PT of 1.5 to 2.0 times control and INR of 2.0-3.0. Check PT/INR before initiating medication and daily until maintenance dose is reached. Assess for bruising, bleeding from GI and urinary tracts, mouth, or nose. Apply pressure after venipuncture. Antidote for warfarin overdose is vitamin K1, aqua mephyton. Dabigatran, Prognosis. A direct thrombin inhibitor indicated to reduce the risk of stroke for patients with nonvalvular atrial fibrillation. Can cause serious and sometimes fatal bleeding. Promptly evaluate signs and symptoms of blood loss. Do not break, chew, or empty the contents of the capsule. Discontinuing abruptly may increase risk of new stroke. Antidote not available. Rivaroxaban, Xarelto. A direct factor XA inhibitor indicated to reduce the risk of stroke for patients with nonvalvular atrial fibrillation. Can cause serious and sometimes fatal bleeding. Promptly evaluate signs and symptoms of blood loss. Do not break or chew tablet. Take with a meal, at the same time each day. Do not stop taking rivaroxaban without consulting your prescribing doctor. Antidote is not available. Thrombolytics. Platelet aggregation inhibitors. Recombinant tissue plasminogen activator, RT-PA. Initiates dissolution of clots by breaking down fibrin. Hemorrhage, especially within the first 24 hours after administration. Minimize venipunctures, protect arterial line sites, assess for bleeding, monitor coagulation studies. Aspirin. Reduces risk of stroke in male patients with recurrent ischemic attacks. May be given in combination with other antiplatelets. Excessive bruising, bleeding, bronchoconstriction, nausea, vomiting, gastric bleeding, urticaria, confusion, drowsiness, tinnitus. May be given in combination with other antiplatelets. Tinnitus and confusion suggest overdosage. Teach patients that aspirin can be harmful if not taken properly. Dipyridamole, percentine. Prevents thromboembolism with heart valve prostheses. Used with coumarin anticoagulants. Hypotension, dizziness. Caution with hypotensive patients. MI, dysrhythmias with use. Constipation, dry mouth. Teach patient to manage orthostatic hypotension. Monitor pulse and blood pressure. Aspirin/extended release dipyridamole, Agranox. Prolongs bleeding time, decreasing the risk of stroke. Rash, diarrhea, itching, bruising. Not associated with neutropenic purpura as with Ticlid. May be given with or without food, assess for bruising. Clopidogrel, Plavix. Reduces risk of stroke by inhibition of clotting. GI bleeding, epistaxis, neutropenia, intracranial hemorrhage, hypertension, dyspnea. Risk of hemorrhage increases if given with aspirin. Give with food. Advise patients of need for periodic lab studies, including liver function tests with long-term therapy. Calcium channel blockers. Nimodipine, Nimotop. Prevents spasms in cerebral blood vessels after a hemorrhagic stroke. Headache, fatigue, depression, confusion, dysrhythmias, hypotension, MI, renal failure. Monitor pulse and blood pressure. Assess for edema. Monitor urine output. Count pulse before each dose, withhold if less than 60 bpm. Pharm capsule. When patients are taking antiplatelet or anticoagulant medications, take care to prevent injuries and bleeding. Discuss nursing care and interventions in the acute phase, include Cincinnati Pre-Hospital Stroke Scale. Once a stroke occurs, it is important to rapidly identify the type and extent of the stroke so that appropriate treatment can be started. The most important aspects of care during the acute phase of a stroke are assessment and stabilization of the patient to prevent further brain injury. This phase is sometimes referred to as hyperacute. Management in this phase focuses on identifying the type and extent of the stroke so that appropriate treatment can be initiated, maintenance or improvement in vital physiologic functions, and support of the patient and family. Assessment. The initial nursing assessment is directed at evaluating the type and extent of the stroke. This includes the time of onset, symptoms experience, and other details related to the onset of the symptoms. Several tools are available to assess patient experiencing signs of stroke. The Cincinnati Pre-Hospital Scale is a quick and easy tool that is often used in the pre-hospital phase by emergency medical technicians. This is a 3-step test period. It assesses facial muscles, arm movement, and speech function. Abnormality in any of these strongly suggests that the patient may be having a stroke. Nursing assessments should also reveal factors for CVA and identify nursing care needs of the patient. Cincinnati Pre-Hospital Stroke Scale. The patient is asked to show teeth or smile. Normal, both sides of face move equally well. Abnormal, one side of face does not move as well as the other side. The patient is asked to close both eyes and hold both arms straight out, with palms up for 10 seconds. Normal, both arms move at the same time, or both arms do not move at all. Abnormal, one arm does not move, but the other does. The patient is asked to repeat a simple phrase such as, "You can't teach an old dog new tricks." Normal patient uses correct words with no slurring. Abnormal patient slurs words, uses the wrong words, or is unable to speak. The health history may be obtained from the patient if he or she is able to communicate. An introduction to the patient, study his or her ability to understand language and respond verbally and non-verbally. Responses to simple yes or no commands provide a good basis for initial assessment. Evaluate verbal responses, facial expressions, and physical reactions for appropriateness. If responses are not appropriate, try to identify the source of difficulty. If the patient has trouble finding words, needs help to respond, does not speak fluently, and cannot provide data needed, this should be documented. Note the name of the informant and assess the patient orientation to the person, place, and time. In the history of present illness, identify the events that led to the patient seeking medical care. A complete description of the illness includes the initial symptoms and how the symptoms progress. Report past serious illnesses or conditions, including hypertension, heart disease, diabetes mellitus, liver disease, gout, head trauma, and previous strokes or TIAs. In addition, note previous hospitalizations, operations, and injuries. Family history. The health history includes a family history of neurologic as well as strokes or cardiovascular disease. Review of systems. Ask the patient about significant problems in the review of systems. Important items to assess include weakness, impaired movement, pain, especially headache, dysphagia, bowel or bladder incontinence, visual disturbances, mental or emotional changes, and altered sensation. Functional assessment. The last component of the health history, the functional assessment, addresses the patient's usual activities and health practices. It is important to inquire about activity level, use of adaptive equipment at home, prior disability, dietary pattern, occupation, use of alcohol and tobacco, drug use, interpersonal relationships, and current stressors. These are important elements that will be used to identify risk factors for stroke and cardiovascular disease. Physical examination. During the physical examination, observe the patient's general appearance, responsiveness, and behavior and record any displays of restlessness or agitation. The patient's level of consciousness is important because subtle changes in level of consciousness such as confusion, irritability, or a decrease in level of consciousness may suggest a stroke in evolution or increasing ICP. Measure vital signs. A description of the patient's breathing pattern and effort are especially important. If possible, obtain the patient's weight and height. Inspect the face for symmetry and assess the mouth for moisture and drooling. Then evaluate the alert patient's ability to swallow and inspect the patient's pupils for size, equality, and reaction to light. Conduct a gross vision assessment by asking the patient to read something. Inspect the patient's skin for color and palpate for moisture and turgor. Assess extremities for muscle tone and strength, sensation, and voluntary movement. Instruct the patient to move each extremity individually and observe the responses. Impaired movement or inappropriate response may be caused by aphasia or dyspraxia as well as by neuromuscular damage. The patient who has aphasia has difficulty interpreting messages and may not perform the requested movement for that reason. The patient with dyspraxia may comprehend instructions but be unable to direct the body part to move. Also record any evidence of incontinence or bladder distension. Neurologic checks consisting of evaluating level of consciousness, pupil appearance and response to light, the patient's ability to follow commands, and the movement and sensation of extremities should be conducted frequently. These checks, along with vital signs, are essential to detect increasing ICP if ICP is not being monitored. Ineffective airway clearance and ineffective breathing pattern. To ensure effective airway clearance and breathing, maintain the patient's body alignment and elevate the head of the bed 25 to 30 degrees. Closely monitor the patient's respiratory status. Maintaining a patent airway is a priority for patients who have suffered strokes. Neurologic deficits may cause altered breathing patterns and impaired swallowing, gag, and cough reflexes. Increasing ICP may affect the respiratory center in the brain, causing respiratory depression. If the patient exhibits signs of increased ICP, example rising blood pressure, bradycardia, abnormal pupil response, decreasing level of consciousness, elevate the head of the bed 30 degrees and notify the physician. After a stroke, the patient is at risk for airway obstruction for a number of reasons. If the patient is unconscious, the tongue may fall back and block the airway. A side-lying position helps to prevent such obstruction. An oral or nasal airway is sometimes used to keep the airway open. Immobility and dehydration cause thick secretions to be retained in the respiratory tract, possibly leading to pneumonia and atelectasis. Good hydration helps to thin respiratory secretions for easier expectoration. Dysphagia may cause the patient to aspirate fluids or food, causing airway obstruction and contributing to the development of pneumonia. Pneumonia is, in fact, the most frequent cause of death after stroke. Suctioning and frequent position changes can help to prevent aspiration and promote removal of secretions. Respiratory treatments for the patient, with regular reminders to do deep breathing exercises, can be helpful. Forceful coughing may be discouraged in the acute phase after a hemorrhagic stroke because it tends to increase ICP. Ask the physician if and when coughing is permitted. Administer oxygen therapy as ordered. Risk for injury. Many factors place the stroke patient at risk for injury. Seizures may occur, causing the patient to lose consciousness and to have abnormal motor activity. Therefore, it is important to raise bedside rails and pad them according to agency protocol to reduce trauma if the patient strikes the rails. During a seizure, turn the patient to one side and move hard objects away from the patient. Never force anything between the patient's clenched teeth. To do so may injure the teeth and gums. Additional information about seizures is presented in Chapter 27. Safety precautions are also essential for confused patients and patients with motor impairments. Orient patients to their surroundings and explain why they should not get up unassisted. The staff must respond promptly to the patient's calls for help. Although restraints are needed at times, they should only be used as a last resort because they often agitate the patient and can actually cause injuries. A bed check system may be of more benefit when the patient is having difficulty understanding directions. Get sufficient help or use mechanical devices to assist the patient in and out of the bed. Sensory perceptual problems in the stroke patient may include visual disturbances, sensory deprivation or overload, and impaired tactile sensation. Often the visual disturbances are diplopia, double vision, loss of the corneal, blink, reflex, ptosis, drooping of the upper eyelid, homonymous hemianopsia, and inability to close the eyelids on the affected side. All of these pose threats to safety and self-care. They may also contribute to confusion. The cornea is susceptible to injury when not protected and, in healthy patients, kept moist by the closed eyelid, and the blink reflex. Artificial tears may be used to provide moisture in patients with disturbed corneal reflex. Patients who have homonymous hemianopsia see only half of the field of vision. Some patients have unilateral neglect, a condition in which visual fields are intact but the patient does not attend to certain parts of the fields. Unilateral neglect is most common. In patients with right brain damage, these patients may not attend to one side of the body and may overlook objects on one side of the visual field. It is helpful to encourage patients to scan the affected side. Differences in the nursing approaches during the acute and rehabilitative phases are well contrasted here. In the acute phase, position patients with homonymous hemianopsia so that their unimpaired side is approached by the staff, to reduce stress to the patients. In rehabilitation, the patient should be positioned so that deliberate scanning by and use of the affected side are required. This is designed to stimulate return of function. Balanced sensory input is essential to reduce the risk of sensory deprivation or overload. The environment should be pleasant but not overly stimulating. Another type of sensory disturbance after stroke is diminished sensation in affected body parts. The patient who does not feel pressure or pain is susceptible to injury. For example, a paralyzed foot can easily slip between the bed frame and side rails. Catheter tubing under the leg may create pressure that the patient cannot feel. Protect susceptible areas and remind the patient of the need for extra caution. In addition, check positioning of affected extremities to ensure that they are free of pressure and reposition them as needed. If RT-PA is administered for ischemic stroke, the patient must be monitored closely for hemorrhage for 24 to 36 hours. Intracranial bleeding is the most common location of hemorrhage associated with RT-PA therapy. Signs of intracerebral hemorrhage include change in level of consciousness, elevation in blood pressure, deterioration in motor function, new headache, and nausea and vomiting. Treatment of the bleeding requires administration of factor VIII and platelets. Cerebral edema is common after large cerebral infarctions, especially in younger patients. It is most common 3 to 5 days after an ischemic stroke. Early signs of increased ICP include deterioration in level of consciousness and motor function, headache, visual disturbances, change in respiratory pattern, and changes in blood pressure and heart rate. Keep the head of the bed elevated at 30 degrees and maintain the alignment of the head with the rest of the body. Medical interventions include diuretic and barbiturate drugs, hyperventilation, and in some cases surgical intervention. Risk for deficient fluid volume or excess fluid volume. Close monitoring of fluid status is especially important in the acute phase of stroke. Accurate intake and output records are essential. Measure vital signs, compare for trends suggesting excess or deficient fluid volume, and assess the mouth for moisture. In a well-hydrated person, the mucous membranes of the mouth are moist. Evaluate tissue turgor, remembering that it is not a very reliable indicator of fluid status in the older person. Age-related changes in the skin and subcutaneous structures cause a loss of tissue elasticity that may be mistaken for dehydration. Laboratory studies, including urine-specific gravity, serum electrolytes, and hematocrit, are also useful indicators of fluid balance. The patient is at risk for excess fluid volume if excessive intravenous fluids are administered or if the patient's kidneys are unable to eliminate excess fluid rapidly enough. Excess fluid volume may lead to edema and heart failure. Signs of excess fluid volume are fluid intake greater than output, bounding pulse, venous distension, increased blood pressure, crackles in the lungs, and edema. Report evidence of excess fluid to the registered nurse, RN, or physician. The rate of intravenous fluid may be decreased and diuretics may be ordered. Explain to the patient and family the need to temporarily restrict fluids. If the patient is thirsty, frequently provide small amounts of fluids in small containers and record all intake. Factors that place the stroke patient at risk for deficient fluid volume include age, dysphagia, drug therapy with diuretics, and immobility. The stroke patient is likely to be older and older people are less able to conserve water through the kidneys. The patient with dysphagia may be unable to take in adequate oral fluids. If diuretics are given for excess fluid volume or increased ICP, they can precipitate excess loss of water and electrolytes. The patient with motor deficits may not be able to obtain fluids independently. Deficient fluid volume contributes to constipation, skin dryness, urinary tract infections, and renal calculi, stones. Signs of deficient fluid volume are a thready pulse, tachycardia, low blood pressure, low urine output, concentrated urine, dry mucous membranes, and sometimes confusion. Report evidence of deficient fluid volume to the RN or physician. If intravenous fluids are being administered, the physician may order an increase in the hourly flow rate. Fluids may also be given through enteral feeding tubes. To reduce the risk of deficient fluid volume, monitor the fluid intake record to ensure that the patient is getting at least 8 ounces glasses of fluids each day, unless contraindicated. All staff and family members should know to offer fluids and record the amounts taken. Place fluids within sight and easy reach of the patient and explain the need for adequate hydration. If the patient has hemiplegia, the fluids must be placed on the non-paralyzed side. Spill-proof containers that are easily held with one hand can facilitate independent drinking. If the patient is able to take oral fluids but has difficulty swallowing, it is important to proceed slowly. Have suction equipment on hand in case of aspiration. Thin liquids are more readily aspirated. Jell-O, ice cream, popsicles, and frozen juice may be substituted to provide adequate fluids. Thickening agents can be added to other liquids as needed, as prescribed by the SLP. Imbalanced nutrition, less than body requirements. The patient's nutritional status is of concern throughout stroke treatment. Factors that may lead to inadequate nutrition include dysphagia, paralysis, difficulty chewing, and depression. The patient who is malnourished is at risk for skin breakdown and infection. Obesity hampers mobility and can interfere with rehabilitation. The patient who has dysphagia may not be able to consume adequate nutrients orally. Sometimes a nasogastric tube is inserted for feeding purposes. The physician may order TPN for the malnourished patient. Aggressive treatment of dysphagia is delayed until the rehabilitative phase. Dysphagia often resolves spontaneously during the first few months of recovery. Feeding the dysphagic patient is discussed in Chapter 39. If the patient has a nasogastric or nasointestinal feeding tube in place, check its placement and residual according to agency policy. Be certain to provide the correct formula and to ensure that it flows at the prescribed rate. Bolus feedings may be ordered at intervals or pumps may be used to dispense continuous feedings. Keep the head of the patient's bed slightly elevated to reduce the risk of fluid flowing back into the esophagus and being aspirated. The nasogastric tube irritates the nares and the nasal passages. Gently cleanse the nares several times a day. Concentrated formulas may cause diarrhea. If that happens, the physician should be consulted about diluting the formula or changing to another type of formula. TPN is given through an intravenous line inserted in a large vein, a central line. Unlike enteral feedings, the flow of TPN fluids is always controlled with a mechanical infusion pump. The nurse hangs new bottles of prescribed fluids. Take special care to prevent air from entering the tubing. The insertion site also requires special care to prevent infection. Change dressings according to agency protocol, using strict aseptic technique. Patients on TPN may develop hyperglycemia, therefore, it is important to monitor blood glucose levels at regular intervals. Care of the patient receiving TPN is explained in Chapter 9. Ineffective thermoregulation. After a stroke, the body's temperature regulating mechanism may be impaired, causing the temperature to rise. Metabolic processes that are also in play may increase the body temperature. It is important to monitor the patient's temperature and treat elevation promptly. Fever is treated aggressively, most often with antipyretic drugs. Some studies even suggest a decrease in infarction size in those patients aggressively treated for hyperthermia. Always assess the patient for an underlying infection as for any temperature elevation. Potential cause. Risk for acute confusion. After a stroke, patients may suffer functional losses, alterations in sensation and perception, and impaired communication. In addition, they find themselves in the hospital, where they are poked, monitored, and prodded by strangers and where days and nights all seem the same. All of these factors combined can cause the patient to become disoriented or confused. Neglect associated with right brain strokes may also be manifested as denial. In extreme cases, patients deny that they have even had a stroke. To orient patients, introduce yourself as often as necessary, remind patients where they are, and tell them what is being done and why. Be sure that eyeglasses and hearing aids are worn if the patient normally uses them. In addition, place clocks and marked calendars in view and tell the patient what time it is and what to expect next. Confused patients require frequent reassurance and reinforcement. Instructions and information should be concise and repeated as needed. Sometimes a familiar person can be helpful with a confused patient. If the visitor is disturbed by the patient's behavior, provide guidance on how to deal with the patient. Impaired verbal communication. The alert patient who has aphasia is understandably anxious about his or her inability to speak, to understand words, or both. Use brief, clear statements accompanied by gestures, pictures, and facial expressions. Questions that can be answered with yes or no may allow the patient to respond more easily. Pause attentively when the patient struggles in respond. Excessive chatter can be distressing to the aphasic patient. Explain the communication problem and approaches to the family. Speech therapy may be initiated once the patient's medical condition is stable. Speech rehabilitation is discussed further in the section titled Nursing Care in the Rehabilitation Phase. Impaired physical mobility. Impaired motor function is common after stroke and places the patient at risk for complications of immobility. Skin integrity. The potential for skin breakdown in this patient population is great because of motor impairment, altered consciousness or sensation, poor nutritional status, and incontinence. Measures to maintain skin integrity include cleanliness, pressure relief, and good hydration and nutrition. When skin is